Hello, I'm Jan Basile, and I'm speaking with Dr. Jami Conti about the three main areas of concern in the treatment of atrial fibrillation, the most common arrhythmia that a primary care clinician encounters. Jami, what's the latest on rate versus rhythm control in Afib?
Well, Jan, as you know, several years ago now, the Affirm trial was published, and that trial sort of changed how we approached atrial fibrillation. Prior to that study, we thought just about everybody deserved at least one chance to be in normal sinus rhythm, thinking that sinus rhythm helped with quality of life, improved mortality. Perhaps those patients in sinus rhythm did not need to take Coumadin long term, and that in sinus rhythm maybe their risk of stroke was less. The Affirm trial compared the rate control strategy with the rhythm control strategy, and surprised everybody by demonstrating that there really was no difference in mortality, quality of life, stroke risk, etc. And so although the outcome wasn't that rate control was better than rhythm control, the outcome did tell us that rate control was a reasonable management strategy. And so from that trial, we took the take-home message that if patients, for example, were asymptomatic, or you couldn't maintain sinus rhythm, or you didn't want to maintain sinus rhythm for a given reason, that a rate control strategy was perfectly acceptable.
That's interesting. And when I achieve rate control, what's the target for the rate control?
So traditionally, we've been, especially in the EP world, because we worry about tachycardia-induced cardiomyopathy, we've been really strict about what we call adequate rate control. And for the most part, that was a resting heart rate in the 80 to 90 range, with an exercise heart rate up in about the 120, 130 range. There have been a couple of recent studies that have pushed us to be just a little bit more lenient on that, and perhaps not hammer our patients with so many beta blockers and calcium channel blockers, and maybe let them feel better. One was a trial looking at rate control, lenient versus strict. Lenient being a resting heart rate of 110, strict heart rate less than 90. And interestingly, it turns out there was no difference in terms of outcome in the patient populations. So it lets you be a little bit nicer to your patients in terms of how many medicines you make them take. The other interesting trial that was looking at rate control had to do with our heart failure patients. It was a rate control versus rhythm control study. And they, because we've always believed that patients in heart failure would do better in sinus rhythm because they have their atrial contribution. This study looked at that, and in fact, in heart failure patients, there's not really a difference in the rate control versus rhythm control strategy. So same sort of thing as Affirm. It's not better to do rate control, but it's an acceptable strategy even in our patients with heart failure.
Very good. So the other issue that's really concerning is the risk of stroke in non-rheumatic atrial fibrillation. And primary care docs always wrestle with aspirin versus warfarin, and now we've got dabigatran out there. How should we be approaching that?
So the way I approach it has nothing really to do with the therapeutic strategy that you take. And by that I mean it doesn't matter if you decide on rate or rhythm control. That doesn't change the patient's risk profile and whether or not they should be on anticoagulation. So in the most recent years, we use the CHADS score or the CHADS-VASc score. And if the patient qualifies or from those scores deserves anticoagulation, they deserve anticoagulation whether you have them only rate controlled or whether you get them back into sinus rhythm. Then your choice, aspirin doesn't really work. Aspirin is not a great anticoagulant for stroke risk. And your choice then becomes either Coumadin or Pradaxa. Pradaxa was recently released. It has a lot of proponents. A lot of patients really want to take it. I mean, I'm sure you've had patients beating down your door to switch from Coumadin to dabigatran, which is the generic name, and I have two, and it's a perfectly acceptable substitute for Coumadin. I have a few concerns about it, and we'll have to see how these play out. I worry a little about in our patients. I mean, I don't know about your patients. A lot of my patients are really elderly, and so I worry in the patients who might fall and hit their head and have some sort of intracranial issue that dabigatran is not reversible, or there's no antidote right now. Although I've heard that it is partially dialyzable. Nevertheless, in the background, it concerns me, and I share that concern with my patients. But you know, it's an acceptable alternative, and many of our patients are just delighted to take it because of the no measurement of INR property.
So warfarin much better than aspirin, and if they're on warfarin and doing well, no need to switch to dabigatran unless they have an urge or a need or somebody wants that conversion to occur. Doing well on warfarin, keep it going just like they're doing.
That's my strategy. I have not actively switched patients from warfarin to dabigatran. If they ask me, I do.
Okay, and then the last question has to do with your area of expertise specifically, and that's ablation. Primary care doc, patient is rate controlled, they're on warfarin, INRs between 2 and 3, and a family member calls you up and says, what about ablation? Why aren't you offering that to my father? What's the primary care doc to say?
So it's a good question. We get asked that question all the time. You have to put ablation into context. For atrial fibrillation, it's not the same kind of ablation as, for example, WPW or atrial flutter. Those ablation techniques are almost 100% successful. And so for those patients, it's a terrific treatment strategy. Atrial fibrillation ablation is also a very nice treatment, but you have to know what the limitations are, and you have to pick your patient population appropriately. It is not first-line therapy for treatment of AFib. It has a complication profile that's higher than regular ablations, with a quoted serious complication rate of about 6%, which is unusual for something in the electrophysiology laboratory. We like to see patients that have tried several antiarrhythmic drugs and failed them prior to sending them to the ablation laboratory for that reason. It's also the success profile is not 100%. The ideal candidate would be somebody with paroxysmal atrial fibrillation, totally normal heart, sort of young, healthy person who wants to get rid of this thing and has tried several antiarrhythmic drugs with no success. As the patient gets more complicated and has more comorbidities, as the atrial fibrillation gets more persistent or more frequent, the success of the ablation decreases, and so the risk-benefit changes for the patient. So it's a little more complicated question than just WPW ablation.
But they have to be symptomatic.
Absolutely. It's a wonderful point. We have patients come to ask, well, I just want to get rid of the atrial fibrillation. Then I don't have to take Coumadin. First of all, those two sentences don't go together. And again, the therapeutic strategy doesn't change whether or not you need anticoagulation. So just because you ablate the AFib, the Coumadin does not necessarily go away. Second of all, AFib ablation has too high of a complication profile to be offering it to people who are completely asymptomatic. What are you fixing? Right. If they're asymptomatic anyway. And our guidelines are very clear on that. It's second-line therapy, and it's for symptomatic patients. And that's a really good point.
Very good. Well, I want to thank you very much for joining us at the annual meeting of the SMA. Hope you've enjoyed the program.
Thank you for having me.